Hello, my name is Josh Schrecker, and I am part of the clinical team at Aegis Sciences Corporation. Thank you for taking the time to watch this recorded presentation regarding Aegis InterACT RX drug interaction testing. While reviewing this presentation, I would like for you to consider the following questions. How many of you prescribe medications that are prone to either pharmacokinetic or pharmacodynamic interactions? How many of you treat patients with chronic comorbid diseases? And how many of you utilize medication reconciliation in combination with clinical decision support tools at each visit to help identify drug-drug interactions in your patients? The presentation will begin with a brief overview of drug-drug interactions and how they can negatively impact patients. I will also discuss the current standard of care available for identifying DDIs. During this time, I will provide some information about some of the complexities associated with identifying DDIs, as well as information about how these complexities may contribute to misidentified interactions. I will then discuss the capabilities and functionalities of the InterACT RX test, including its place in practice. This will be followed by a brief case that demonstrates the applicability of this test to patient care. To me, the description on this slide is the simplest way to define a drug interaction. Interactions occur when two or more substances are ingested, and there's a change in the concentration or effects of one or more of the ingested substances. It is important to remember that interactions don't necessarily always occur between two prescription medications. They can involve over-the-counter medications, herbal supplements, and can even occur secondary to ingestion of certain foods. This is important as some studies demonstrate that around 50% of patients use supplements or over-the-counter products concurrently with prescription medications. Before moving on, I would like to provide high-level definitions and examples for two terms that you may hear in relation to interactions. Pharmacokinetic interactions often involve changes in the absorption, metabolism, or elimination of a drug. Most often, I think about kinetic interactions in terms of how one ingested substance impacts the metabolism of a prescription product. Inhibition of oxycodone metabolism by azole antifungals or macrolide antibiotics due to the inhibition of a cytochrome P450 pathway is a classic example of a pharmacokinetic interaction that can contribute to adverse effects associated with oxycodone. Pharmacodynamic interactions can occur when two ingested substances have additive or antagonistic effects on one another. A classic example of this type of interaction is the additive CNS or central nervous system depressant effects that can occur secondary to co-ingestion of opioids and benzodiazepines. When caring for patients, why should a healthcare provider be concerned about drug-drug interactions? Over time, we've grown to understand that DDIs are a significant preventable cause of adverse drug events. Additionally, we understand that ADEs are a significant cause of morbidity and mortality in patients. ADEs contribute to hospitalizations, increased length of stay once hospitalized, and an increased healthcare expenditure versus those patients that have not suffered an ADE. Though negative outcomes don't always occur when interacting medications are ingested, it is important to recognize when they do occur in order to mitigate the risk of an adverse drug event. It is also important to realize that the effects of a drug-drug interaction aren't limited to adverse effects. Therapeutic failure of a prescription medication can also occur secondary to a DDI, often due to induction of metabolism of the drug to an inactive metabolite. Additionally, DDIs can contribute to intolerance to prescribed medications, and this can lead to medication non-adherence, a known significant barrier to patients meeting treatment goals. When speaking to providers about drug-drug interactions, many state that they are comfortable with processes that are in place to help them identify and mitigate DDIs. To ensure that all of those reviewing this presentation are on the same page regarding the standard of care for identifying DDIs, I wanted to provide an overview of this process. Medication reconciliation and drug utilization review, which typically take place at the point of prescribing or dispensing of a medication, are the cornerstone of DDI identification. These processes involve collection of an up-to-date home medication list from a patient, which should include assessment for new dietary habits or non-prescription substance use. The medication list is then input into the patient's medical record. Once in the medical record, most healthcare providers are privy to automated clinical decision support, a tool that assesses all components of a patient's medical record for drug interactions, amongst other things. At the completion of the assessment, providers receive automated alerts about interactions. These alerts are used to make medication management decisions, including discontinuation of therapy, adjustment of a dose, transitioning to a more appropriate medication, or moving forward with care as the benefits of concurrent ingestion of the two substances outweigh the risk. The medication at that point is either prescribed or dispensed. Now that we've defined drug interactions and discussed their potential impact on patients, as well as reviewed the processes that are currently in place to prevent DDIs from occurring, I would like to discuss some of the complexities of patient care that can render our current tools for identifying DDIs ineffective. First, I would like to discuss the existence of comorbid conditions in polypharmacy and discuss how that not only can cause interactions, but may prevent them from being recognized by a provider. Polypharmacy, which is often defined as recent use of 5 or more medications or substances, impacts a significant portion of the United States population. The CDC reports that around 10 to 15% of patients admit to taking more than 5 medications daily. Other studies have even demonstrated that polypharmacy rates are higher. Polypharmacy is a major driver for interactions, as studies have demonstrated that there is a proportional increase in interactions occurring as medications are added to a 5-drug regimen. Chronic comorbidities go hand in hand with polypharmacy. Patients with chronic pain often suffer from other diseases, including but not limited to mental health disorders, hypertension, diabetes, and hyperlipidemia. Those with complex medical histories often require multimodal treatment regimens for each disease state and may require treatment from multiple specialists. Their medication regimens oftentimes meet polypharmacy criteria due to their complexity. Although electronic medical records and automated clinical decision support have improved providers' ability to identify interactions at the point of care, there are still significant gaps associated with these processes. Medication discrepancies, defined as a lack of agreement between a patient's electronic medical record and their self-reported medication use, significantly hinder healthcare providers' abilities to identify DDIs. These discrepancies occur at an alarming rate, with one study demonstrating that 99% of patients assessed had at least one discrepancy in their medical record when compared against their home medication list. Why is this important? Clinical decision support tools rely on complete medical records to accurately identify DDIs and alert providers about interactions. Without accurate records, alerts can't be triggered, and DDIs may go unnoticed. As we had previously mentioned, it is well established that drug interactions contribute to adverse drug events. Despite innovation and improved processes for identifying DDIs, they are still occurring at an alarming rate and are likely secondary to those factors that have been discussed on this slide. Providers often face a tough task of managing patients with multiple comorbidities, and oftentimes those with low health literacy taking numerous medications may misreport their home medication lists, and that can contribute to improper identification of drug-drug interactions. Due to the understated complexity of this aspect of patient care, InterACT has developed a definitive drug-drug interaction test known as InterACT Rx. InterACT Rx is a diagnostic test developed to address the known critical deficiencies and gaps in the current standard of care for preventing and mitigating drug-drug interactions. Testing is performed via liquid chromatography tandem mass spectrometry, a definitive testing method, and allows for identification of recently ingested substances that are capable of interacting with one another and impacting patient care. Detection of substances is paired with an assessment for potential interactions and is coupled with clinically actionable descriptions and potential severity for each interaction that is identified. Previously, we discussed risk factors that contribute to DDIs and potential downstream adverse drug events. InterACT developed the InterACT Rx test in response to a thorough understanding of the gaps in care associated with current medication reconciliation processes. Through use of medication claims data, scientific publications continue to demonstrate that drug-drug interactions occur at an alarming rate. Specific to patients undergoing pain management, studies have demonstrated that 30 to 40% of patients were concurrently prescribed 2 or more substances that were capable of interacting with one another. As I previously mentioned, the gaps in care associated with medication reconciliation and clinical decision support have been well characterized. Due to a reliance on subjective information, these systems are incapable of identifying interactions between ingested substances unless they have been accurately reported by patients and meticulously entered into the patient's medical record. Finally, studies show that interruptive alerts are overridden at an alarming rate. One study actually found that 95% of alerts that were triggered by clinical decision support were overridden by providers in a hospital setting. This demonstrates a limitation in the functionality of clinical decision support and also exhibits another mechanism for interactions to be overlooked. So what does this test include? InterACT RX testing detects more than 100 interacting medication substances, supplements, food products, and includes both prescription and non-prescription medications. The components of this test were selected based on their ability to contribute to both kinetic and dynamic interactions. The test includes, but is not limited to, antiarrhythmics, antidepressants, antipsychotics, anticonvulsants, antihypertensives, antimicrobials, and foods and supplements. Importantly, the test includes the ability to detect non-prescription substances, herbal supplements, and food products that are known to contribute to DDIs. And this is important because use of these types of medications and substances often go underreported or completely unreported during medication reconciliation. How is testing completed? The process of testing is likely very familiar to you as a healthcare provider, as it has similarities to medication compliance testing and can be used in conjunction with a compliance test. A urine specimen is collected from a patient, and that sample is shipped to our laboratory for qualitative mass spectrometry testing. Once testing is complete, all positive substances that are identified secondary to testing that is ordered by a healthcare provider are assessed for interactions. We at Aegis feel that this is important. This is not purely an assessment of what your patient states that he or she is taking, but is instead a determination for the risk of an interaction to occur based on recently ingested substances that are identified through testing of a urine specimen. This is what differentiates this product from clinical decision support that is currently available. Finally, once testing and the interaction assessment is complete, a report that includes all detected substances, interacting drug pairs, interaction severity, and clinically actionable information is delivered to the provider. So when would it be appropriate to utilize this test? First, I want to emphasize that this is not a test that should be completed on every patient during every visit. This test is most applicable in clinically difficult situations when providers are seeking objective information about what is potentially having a negative impact on a patient. This can be particularly helpful for patients exhibiting unwarranted adverse effects or a lack of therapeutic efficacy of a prescribed medication that also have a complex medical history. If patients are vague when self-reporting home medications and are having significant difficulties with their prescribed medications, this test can offer objective information about what the patient has recently ingested that can impact his or her therapy. The information provided by the test results can be extremely valuable to clinical decision-making prior to titrating a dose or discontinuing a medication for a patient that was previously stable on that therapy. Demonstrating clinical utility requires evidence of improved patient outcomes and/or changes in physician management that result in improved patient outcomes. The clinical utility of Aegis InterACT RX test for the objective and definitive identification of drug-drug interactions in patients is well established after more than 2 years of testing of over 350,000 patient specimens with reported interacting substances along with the severity of the detected interactions. Retrospective and prospective findings have been published across 4 different publications that are pictured here that demonstrate both the clinical validity and utility of the InterACT RX test and its impact on patient care. This slide summarizes the findings of our first retrospective study, which consisted of about 15,000 patients with either chronic pain or behavioral health conditions that underwent InterACT Rx testing. The analysis looked at one result per patient, and patients were tested between June and November of 2016. The patients were tested across 326 different healthcare practices across 34 different states. Results of this analysis demonstrated that 38% of participants had at least one interaction, either a drug-drug or drug-food, or both, identified based on the substances that were detected in the submitted specimen. Around 1 in 10 patients had a severe or contraindicated interaction identified. These interactions were detected between ingested substances, meaning that providers were prescribing two substances they either knew to lead to a severe or contraindicated interaction, or these interactions involved one or more substances the provider was unaware of. And these providers are going to be physicians that were capable of using and had access to clinical decision support. Our patient population within this study had about twice as many polypharmacy patients based on the detection of 5 or more substances in their urine specimen as the general population. The most recent CDC survey on medication use reports that only 10 to 15% of patients have used 5 or more medications within the last 30 days. This is important because polypharmacy patients are more likely to have an interaction and are at a greater risk for severe or contraindicated interactions, as we saw from the findings of the study. This slide summarizes the findings from our second retrospective publication that was completed in conjunction with Navigant Consulting. The study assessed results of 262 patients that had at least one interaction identified across 2 practice sites that partnered with Aegis for the study. The point in time at which this DDI was identified by the InterACT Rx test and a result was provided to the physician that ordered the test is referred to as the index date. The patients within this study were primarily being treated for chronic pain and behavioral health indications, but not for substance abuse. Care for each patient was compared for a time period prior to and after the index date to determine what sort of changes to the patient's care may have occurred subsequent to use of InterACT Rx testing. Our goal was to assess the impact of the test on the frequency of drug-drug interactions identified in patients undergoing treatment for chronic pain and or behavioral health conditions, patients' healthcare resource use, and providers' prescribing behavior. There were statistically significant reductions in the number of outpatient visits per patient and outpatient healthcare expenditures per patient post-index, meaning that changes in care possibly led to a reduction in the number of adverse effects that previously contributed to requirements for more intensive care pre-index. Opioid prescriptions actually decreased post-index as well. Providers that were identifying interactions involving opioids may have opted to transition patients to a different therapy to reduce the risk of adverse effects associated with the opioid interactions identified at the index point. For those patients that had a follow-up test after the index test, there was a significant reduction in the number of severe and or contraindicated interactions identified on that index test based on the results that we saw in the follow-up test. We will now move on to discussing the results of our prospective study completed in collaboration with Cure Healthcare. This was known as the DESCARTES study, with the acronym representing DDI Effectiveness and Clinical Awareness Randomized Control Trial. This study was completed in a before and after manner, and results that are discussed in relation to this study were developed around the results of clinical performance and value vignette scores. The simplest way that I can define a clinical performance and value vignette, or CPV, is that it is a web-based platform that includes a simulated patient case. Cases are developed to represent a common patient. In our patients that were used within this study, the patients were taking one of 3 commonly prescribed medication classes: opioids, other CNS depressants or central nervous system depressants, or antimicrobial medications, in addition to common substances like over-the-counter products, supplements, foods, potentially ingesting alcoholic beverages, or other prescription medications that could cause an interaction. Providers would work through these CPVs or these web-based platform cases in the same manner they would if they were treating a real patient. When treated, all patients presented to the provider with a chief complaint originating from a drug-drug interaction. Patient care within the CPVs is assessed over 5 domains: providers' ability to appropriately take a patient's medical history, performing a physical, ordering diagnostic testing, making a diagnosis, and creating a treatment plan and follow-up. The scores of these CPVs across these 5 domains were then scored independently by 2 physicians. So Phase 1 of the study analyzed treatment scores from the CPVs for 330 board-certified primary care physicians. In a baseline survey, 99% of the participating physicians claimed that they reconciled medication lists and assessed patients for drug-drug interactions regularly. Within this study, based on the completion of the CPVs and the scoring of those, the care for those patients, we found that despite indications that the providers were regularly reconciling medications and utilizing standard tools for identifying drug-drug interactions, recognition that a DDI occurred and contributed to a patient's chief complaint only occurred in about 15% of patients. Specific compounds contributing to the interaction were recognized in less than 1% of patients. Due to the limitations in the ability to identify interactions within these patients, attempts to coordinate care with another provider that could have prescribed the interacting drug were limited, and patients were rarely counseled on the dangers of the drug-drug interactions. This slide discusses the second phase of the prospective study. Those providers that completed Phase 1 and agreed to participate in Phase 2 were randomized into 3 groups. They agreed to complete 3 more CPVs or treat 3 more patients. 2 of the 3 groups were exposed to an educational intervention. The control group had no change in the access to InterACT RX results and no education about drug-drug interactions or definitive testing for drug interactions. Intervention Group 1 had access to InterACT RX results while completing their second set of CPVs, and Intervention Group 2 were able to order the InterACT RX results while completing their second set of CPVs. Our goals here were to demonstrate, did patient care get better when the results were available, and if so, does this demonstrate the utility of the test? Bullet points 1 and 2 compare the change in care, so comparing change in care of the first 3 patients prior to the educational intervention versus the last 3 patients for Intervention Group 1. So that is the group of providers that were provided the InterACT RX results during completion of the second set of CPVs. In Phase 2, these providers identified that an interaction occurred in 40% more patients and realized a 26-fold improvement in the ability to identify the specific interaction or interacting substances that were impacting patients. This demonstrated that providers were much more likely to realize that an interaction had occurred and had a greater ability to actually diagnose the substances involving the interaction. Bullet points 3 and 4 compare the care provided to patients in Phase 2 of the studies between those providers that did and did not order InterACT RX testing that were part of Intervention Group 2. As a reminder, Intervention Group 2 were those providers that received an educational intervention and had the opportunity to order the InterACT RX test in the second phase of the study, so after the educational intervention. Those providers that actively ordered the test and reviewed results stopped the interacting medications in 58% more patients that were treated and counseled 23% more patients about the risks of drug-drug interactions. This demonstrated that those that ordered the test saw significant improvements in patient care once the drug-drug interaction was identified. All in all, I believe that the results of these 4 studies speak for themselves and demonstrate the validity and utility of InterACT RX testing in patient care. I would now like to cover a brief case to demonstrate additional application in practice. This case is representative of an established pain management patient that has contacted her physician between visits and is describing an intolerance to therapy, which includes frequent falls, and is experiencing overall adverse effects that could be due to her prescription therapy. Her past medical history includes hypertension, hypercholesterolemia, and depression, in addition to the pain management conditions for which she's being treated. This patient is being prescribed Zohydro ER, 20 milligrams twice a day. When assessing the patient's recent medical changes, the patient states that they are taking a new medication for heartburn. That is all the information that is provided in this case. When assessing the patient, the provider determines that they are going to order both a medication compliance test to determine if the patient is taking the prescribed Zohydro in conjunction with an InterACT RX test. The compliance results demonstrate that the patient is taking the prescribed therapy, but the drug-drug interaction test found that the patient was also taking both lansoprazole and clarithromycin. And as you can see here, the results of the InterACT RX test demonstrate that clarithromycin and hydrocodone could result in a severe interaction. The mechanism of this interaction is metabolic inhibition of hydrocodone metabolism by clarithromycin, which can contribute to elevated active drug concentrations of hydrocodone and could cause adverse effects in this patient. When the provider followed up after the results of this test, it was determined that the patient had actually been prescribed a treatment regimen to eradicate H. pylori that included both lansoprazole and clarithromycin. Although the patient believed this was simply a new medication for heartburn, it included medications that could interact with her prescribed therapy, and the regimen typically lasts for 10 to 14 days and is utilized to reduce recurrent gastric reflux in some patients. So again, although the patient believed that this would not be something that can significantly contribute to the adverse effects that she was impacted by, the test itself demonstrated that there were interacting substances that were being ingested by the patient, and these interacting substances had bypassed the typical medication reconciliation processes based on the patient's subjective self-report during her assessment. If you have any additional questions about the InterACT RX test, I would encourage you to reach out to our clinical team. Our telephone number and clinical team email can be found here. We would love to speak with you about the results.